Very good evening to one and all. I am Arpita, the moderator for today's session from the IGCP group. The topic that we are going to address today in our webinar is second generation sulfonylurea in the management of type 2 diabetes. Now, to give a brief on the topic, the second generation sulfonylureas are potent oral hypoglycemic agents used to manage type 2 diabetes. They stimulate insulin release from pancreatic beta cell, reducing blood sugar levels. These drugs offer effective glycemic control but require careful monitoring due to risk of hypoglycemia and weight gain. Now, to give us more information on this topic, we have someone who is an expert in this topic, none other than Dr. Abhay Shahu sir. He has done MBBS from the MKCG College, Medical College. He has done MD and he has done DM in endocrinology and metabolism from AIMS, New Delhi. So he is professor at the Department of Endocrinology and Metabolism at the IMS and SAM Hospital, Kalinganagar, Bhubaneswar, Orissa. He is a senior consultant endocrinologist at Apollo Hospital, Bhubaneswar. So, with this very brief introduction of Sir, now I would request him to please start with the topic for today. Over to you, Sir.
Yeah. Thank you, Arpita. Am I audible?
Yes, sir, audible.
Yeah. Thank you, Arpita, and thank you the team IGCP for today's webinar. So today we are going to discuss the position of second generation sulfonylureas in the current eras. As our moderator from the beginning has given some information that this second generation sulfonylureas has risk of hypoglycemia, there is a risk of weight gain. I think we should know that these are all myth for particularly this new generation sulfonylureas. So this is the thing what we are going to discuss today's topic. So before going to the topic, because nowadays we have an era where SGLT2 inhibitors, DP4 inhibitors, GLP-1 shift agonist, all are playing a big role, and everybody actually is running after this drug. So from the beginning here, I want to tell: change your opinion, keep your principles, change your leaves, but keep your intact roots. So that means that here we are going to discuss certain things which is actually for last 50 years it is going to not only healing the all diabetic patients, also still date it is giving the maximum number of people are using that drug. So here this is Afghan proverb: five fingers are brothers but not equal. So here we can tell that all drugs are complementary to each other, but they are not behind each other, or they are not actually against each other for particularly management of diabetes. So in this OID of wars, what I am going to do today, that journey of sulfonylurea from 1946. It is the 1942 first time sulfonylurea was described by laboratories, and after that sulfonylurea has actually crossed a lot of studies. It is actually 1970s where UDGP first time shows that tolbutamide increased the risk of cardiovascular disease, so it has been withdrawn from the market. And Advance is the first trial which clearly shows the CV safety of gliclazide modified in 2008. And in 2019, glimepiride CV safety as much as or it is neutral has been actually shown in the Carolina trial. After that, we have again European Society of Cardiology has endorsed this, and in 2023 we have JET study which has again actually endorsed the use of this sulfonylureas. So here today I am going to discuss my agenda in the limb of efficacy. What is the risk of weight gain and hypoglycemia? Then beta cell failure and pleiotropism, durability and cost, simultaneous use of insulin, and CV and renal safety. Let us see the efficacy. Among these all drugs, probably among all OHs, the insulin secretory drugs has the highest potency in the range of 1 to 2%, whereas whether it is alpha glucosidase inhibitors, glinides, bigonides, insulin sensitizers, GLP-1 or DP4, all has actually HbA1c lowering property in the less than 1%. So probably from the HbA1c lowering property, this sulfonylureas have the highest potency. Then the second part is weight gain and hypoglycemia. As actually our moderator also has given, there is a misconception that weight gain is presumed to be one of the major limiting factor of sulfonylurea use. So what is the fact? That there is weight gain is there, and if you are using old generation sulfonylureas, the risk of weight gain is high. But the common sulfonylureas or conventional or modern sulfonylureas like glimepiride and gliclazide, it is associated with very less weight gain, and sometimes we can tell it is almost weight neutralized, or there is almost neutral from the weight point of view. So this is a study of 5-year study in 2016. In one arm, there is metformin sulfonylurea. In one arm, the metformin DP4 versus metformin and thiazolidine were compared. You see, metformin and thiazolidine has maximum weight gain, whereas metformin and sulfonylurea is found to be neutral, and DP4 has actually there is a some sort of minimal weight loss is there. But again, this is not found to be statistically significant. So there is a very small reduction was observed with sulfonylurea, and again, it was not found to be statistically significant. Again, what we saw in the Carolina trial, in the Carolina, you will see linagliptin versus glimepiride. In glimepiride group, initially in the first 1 to 2 years, there is a increase in body weight of around 0.1 to 1 kg, and that is during that period there is a weight loss of around 1 to 2 kg in the linagliptin group. But at the end of the study, you will compare with the baseline, there is almost a 0.5 kg weight loss in the glimepiride group and around 2 kg weight loss in the linagliptin group. So both the groups has lost weight. Again, it is the around linagliptin group has lost 1.5 kg more in comparison to the glimepiride group. And these are the meta-analysis of the several studies. So this is the systemic review of meta-analysis, which has clearly shown that probably all these studies has actually clearly shown that treatment with glimepiride versus DP4, around there is a 2.1 kg difference is there, and it has found to be statistically not significant. So there is no statistically significant weight gain is there in glimepiride group versus DP4 inhibitors. So again, glimepiride over a period, this is the 5-year study taking in 2016, taking close to 3,000 patients, which has clearly shown at baseline the body weight was 91.3 kg. After 5 years, it has increased by only 100 gram, it is 91.4 kg. And strict glycemic control was maintained in sulfonylurea metformin group. The average HbA1c over the treatment period intensification phase was less than 7%. But despite of that, the Zodiac 19 as 39 was clearly shown the weight gain is only 100 gram. Again, that is also again reflected in the advanced trial where gliclazide modified release was used. You see over a period of 5 years, there was absolutely no weight gain. It is only gain of 0.16 kg, that is 160 gram was there. So again, gliclazide modified release is found to be absolutely weight neutral over a period of 5 years. Again, this is not only that use of this sulfonylureas in the normal time, even if this is the steadfast study where gliclazide modified release was used in the Ramadan phase in the Muslim people. What they found that gliclazide MR provides a weight reduction benefit similar to that of vildagliptin. In the both the groups has lost around 1.1 kg. Same gliclazide modified release versus and vildagliptin group. Again, you will see the body weight loss. Body weight in the Ramadan study, same thing, gliclazide modified release shows that there is a 0.5 kg weight loss during the Ramzan phase, and the BMI is reduced by 0.2 kg per meter square during that phase. So what again shows that there is absolutely less number of hypoglycemia. Still, you are giving, even if you are giving during the evening time, before the what the classically they told that before iftar, if you are giving the medicine, still the risk of hypoglycemia is significantly less, and there is a weight loss of around 0.5 kg, and the BMI is also statistically significant loss, even if with the gliclazide modified release group. This is a study in Ramadan. They tried to compare which group of medications has highest risk of hypoglycemia, sulfonylurea, overall sulfonylurea, gliclazide, glimepiride, glibenclamide, and sitagliptin. What they found? The risk of hypoglycemia is almost similar or negligible with gliclazide and sitagliptin, whereas other sulfonylureas has little bit higher risk of hypoglycemia. So again, all Cipri and orbital all has shown similar effect. The risk of hypoglycemia is found to be significantly less in gliclazide and sitagliptin group. Again, gliclazide in the Ramadan, it shows that even if fasting patients can safely maintain glycemic control with the evening administration of gliclazide modified release 60 mg, as I have clearly shown, giving before iftar, and the proportion of patients reporting more than one symptomatic hypoglycemic events during Ramadan was as low as 2.2%. So again, it is found to be statistically very less. And the most important part is the normally that this endogenous insulin sparing effect of this module insulin. If this see this graph, that gliclazide, glipizide, glibenclamide, and glimepiride all can reduce equal blood glucose level, but if you will see amount of insulin being secreted from the beta cells, it is significantly less. This is the what the shows that glimepiride and gliclazide has very significant less insulin secretion in comparison to glipizide and glibenclamide. So the ratio of plasma insulin increase to blood glucose decreased activity was least for glimepiride group, shows that glimepiride has the insulin sparing effects. Then third part of our topic is beta cell failure and pleiotropism. Again, this is this madam has discussed that there is risk of hypoglycemia increases. Again, the beta cell with sulfonylurea, the beta cell failures occurs early, but this is found to be a misconception. The fact is glimepiride improves insulin secretion and also reduces the risk of beta cell failure in type 2 diabetic patients. So this is the study. What Wikipedia has clearly shown, there is no solid evidence for beta cell exhaustion in clinical setting over 6 years of Wikipedia. Diabetes may itself can cause apoptosis of the beta cells. Sulfonylurea are wrongly assumed to cause beta cell death in type 2 diabetic patients. Wikipedia's trial has found its ability to protect against autophagy associated with beta cell death. Again, beta cell exhaustion. Is there any difference within the sulfonylurea? Yes. This is a study has clearly shown that after 6 months of treatment with exenatide or sitagliptin has no effect on the functional beta cell mass as measured with the beta cell capacity, whereas glimepiride appears to enhance the beta cell secretion. So, type 2 diabetes, the beta cell autophagy due to imbalance between insulin secretion and production release, and sulfonylurea can may correct, particularly this glimepiride group can give protection for this autophagy associated with beta cell death. Again, this is a study where actually glibenclamide was compared with glimepiride. You can see that over 5 years, glimepiride therapy has minimal effect on beta cell function, and also in the second part, you see HOMA beta is showing beta cell function is improving, and HOMA IR is showing that there is a significant reduction in the beta cell insulin resistance, which particularly use of this glimepiride. So if you in a single slide, you will see the mode of action. Glimepiride has both the actions, insulin secretory effect and insulin improves in insulin resistance, whereas conventional sulfonylureas, they only causes insulin secretion, and glinides also causes insulin secretion, whereas biguanides and glitazones, they can cause reduction in the insulin resistance. So let us discuss the pleiotropy of this sulfonylureas. To a man with hormone, even if every problem is a nail. So this is the, you will see the pleiotropy. They can insulin, you will see the insulin clearance. It inhibits metabolic clearance rate of insulin. In the glucagon, it inhibits glucagon secretion from the pancreatic beta cell. From the insulin sensitization effect, it improves insulin sensitization and decreases the insulin resistance in the peripheral tissue. In the GLOT transports, glimepiride increases the translocation of the GLOT4 transporters from the low density microsomes to plasma membrane, and it has antioxidant effect in the range of it reduces the toxic advanced glycated end products and also the receptor for age. It has angiogenetic effect. The glimepiride reduces the plasma VEGF and FGF2 receptors, and it's in the vascular health. It reduces GCSF and GM-CSF level and helps in the improvement in the vascular health. If you see the durability and cost point of view, if you see the advanced trial over a period of 5 years, if you see how much people were having HbA1c less than 7%, it is 81%. Even if strict titral control less than 6.5%, around 65%. Even if further stricter control less than 6%, it was 22%. So again, over a period, if you see the how much people are in 5 years are having very significant tightly control, you can see a statistical significant chunk of people has having tight glycemic control. Again, if you see the efficacy and sustainability of modern sulfonylurea versus DP4 in Carolina, again, Carolina has clearly shown there is a initially with particularly with glimepiride, there is a sudden drop in the blood glucose level, which clearly shows that glimepirides are even very early acting and very potent. But over a period of 4 years, 5 years, you see both the graphs are emerging. So it is durable as DP4 inhibitors over a period of 5 years of therapies. Again, sulfonylurea plus metformin, 5-year durability. This is take close to 20,000 people who are newly treated with sulfonylurea DP4 thiazide following metformin therapy failure. Is clearly shown that adding DP4 to metformin is associated with an increased and earlier requirement of treatment intensification comparing to adding a sulfonylurea. That means those who are on sulfonylurea metformin probably their needs treatment intensification in a quite later phase in comparison to those who are on DP4 and metformin. Then again, this is the which one is more durable, sulfonylurea versus gliptin. This is a year calculation. If you see first year, second year, third year, and fourth year, every time sulfonylurea plus metformin gives around 0.3 to 0.5% greater reduction in HbA1c compared to metformin and DP4 inhibitors. And this is 17 years of sulfonylurea use, even if without don't withdrawal. So that means sulfonylurea remains effective even if as long as duration of diabetes up to 17 years. Once you are withdrawing sulfonylurea, most of the patients who are on long-term sulfonylurea and insulin, they suddenly starts experiencing a deterioration of the glycemic control, and also their insulin secretion significantly reduces. So even if after 17 hours, if your patient is on sulfonylurea, they should continue, they should not stop that, even if stopping that causes significant deterioration in the glycemic function. So again, this is one of the study. The second line agents of glycemic control for type 2 diabetes are newer agents better. That clearly shows in this study metformin monotherapy with sulfonylurea, DP4, GLP-1 and insulin all were used. What clearly shows that sulfonylurea incurs significant low cost per quality and result in a long time to insulin dependence. So use of sulfonylurea as a second line therapy for type 2 diabetes generated glycemic control, and the QA quality comparable with those associated with agents but at a lower cost. So again, that shows with a low cost you can give a good standard of life and good quality of life to our patients with if you are using this glimepiride group of drugs. Then with co-use, particularly in comparison to insulin. So combination of insulin glargine, glimepiride and metformin. This is a study in which in one arm glargine plus metformin, another arm glargine plus glimepiride, and third one glargine plus glimepiride plus metformin were given. What clearly shows that if you are giving glargine plus metformin plus glimepiride, they have much more people have significantly reduction in fasting level. Their HbA1c is significantly reduced, and that shows that probably the requirement of insulin is also glargine is significantly coming down if you are actually giving a combination of glargine plus glimepiride plus metformin. So again, there is a significant reduction in dose itself, shows that probably the weight gain will be much less in particularly long duration of time. Again, if you see the sulfonylurea and insulin combination, this sulfonylurea, moderate sulfonylurea may be continued with appropriate precautions with basal insulin. Again, even if you are using pre-mixed insulin once daily, you can use moderate sulfonylurea another time. And if you are using pre-mixed twice daily, and if there is a prandial lyse after lunch, even if a short-acting sulfonylurea can be used or added at the lunch time, which will give a full coverage and it will significantly reduce the HbA1c level. Then the last part of my topic is CV safety and renal safety. We know that ischemic preconditioning and sulfonylurea hypocalcemia, sulfonylurea other than glimepiride and gliclazide abolishes ischemic preconditioning. That leads into result in the larger infarct size. Again, if you are using a glimepiride and gliclazide, probably the ischemic preconditioning is not abolished and the infarct size found to be significantly less. This is a study in 2019. What are the advantage, what are the precaution, basic pathophysiological mechanisms, how glimepiride gives cardiovascular safety. It preserves myocardial preconditioning. It has no effect on the ATP sensitive potassium channels. It has little or no effect on the blood pressure, and also it has no effect on reducing the coronary blood flow. So these are the certain mechanisms by which actually glimepiride gives significant cardiovascular benefit. These are the, let us see some of the data here. This is a study close to 67,100 patients who are first time myocardial infarction versus 67,000 matched controls. What they found, that if you are using newer sulfonylureas like glimepiride and gliclazide, the risk of associated or risk of there may be associated with low risk of myocardial infarction than older sulfonylureas. So this clearly shows that glimepiride gliclazide is better. Then the impact of type of pre-admission sulfonylureas on the mortality and cardiovascular outcome in the diabetic patients with acute myocardial infections. Here, 1,310 diabetic patients with acute STEMI and non-STEMI people are taken. Among sulfonylurea-treated patients, in hospital mortality was lower, those who are on gliclazide and glimepiride. Again, arrhythmia and ischemic complications were also found to be less frequently on gliclazide and glimepiride. This is a meta-analysis of particularly several studies of taking all sulfonylureas, which has clearly shown probably glimepiride and gliclazide are the two drugs which has actually significant less number of mortality risk. All-cause mortality and cardiovascular mortality both are found to be significant less with particularly gliclazide and glimepiride group. Again, let us see different trials of DP4, Ticus, Sabertimi, examine. If we clearly actually or dissect these studies, all are found to be cardiovascular neutral. What they found? The percentage of patient in the sulfonylurea group in the placebo group. In the placebo group, how many people on sulfonylurea? This is close to 45%. And if you will see the percentage of people or patients on sulfonylurea in the study group, again this is close to 55%, 45%. So that shows that even if 45% people who are on sulfonylurea, still they did not alter um, um, the outcome of the trial. Again, this trial found to be neutral. So that again boosts our confidence that probably this modern sulfonylurea has found to be CB neutral. This is Tosca. It is a long-term CB safety of sulfonylurea. Here, glimepiride and gliclazide were compared with particularly pioglitazone. Again, both found to be similar. There is no difference and found to be not statistically non-significant difference between both the groups. Again, the cardiovascular safety of glimepiride, Carolina and Carolina has shows that cardiovascular safety of glimepiride is reassuring and may help our patients of type 2 diabetes world over to avail the benefits of this affordable, efficacious medication. Again, this is another the comparative cardiovascular and hypoglycemic safety of glimepiride in type 2 diabetic, a population-based coach. This is section taking 66,032 sulfonylurea users and shows that glimepiride was associated with lower incidence of all-cause mortality compared to other second-generation sulfonylureas. So this is a safe and smart use of sulfonylurea consensus statement, shows modern sulfonylureas should be preferred over conventional sulfonylureas in view of reduced mortality, better cardiovascular outcome, better renal protection, and modern sulfonylureas should be preferred over conventional sulfonylureas in patients at increased risk of cardiovascular disease with or without cardiovascular disease. Again, this is an international expert opinion which has clearly shown that good glycemic control can positively influence the long-term development of cardiovascular and CVD and mortality. Cardiovascular safety outcome trials offers certain advantages that are clinically relevant. This includes uniformity of reporting and recognition of specific off-target action of molecules. Second and third generation sulfonylurea is not associated with increased risk of all-cause mortality, CV mortality, myocardial infarction, and stroke. And modern sulfonylurea is preferred is over conventional sulfonylurea in patients of diabetes and cardiovascular disease. So this is again the consensus recommendation of sulfonylurea and sulfonylurea combinations. It's an international task force guideline which has again endorsed that probably this modern sulfonylurea in combination of metformin can be safely used and can be prescribed to people who are in need for this comparison. Again, now this is the last part where we can discuss what are the renal events. If you are in the see the advanced or dissect the advanced trial, the new onset microalbuminuria, the new onset macroalbuminuria, or new or worsening of nephropathy, all are actually significantly reduced with in the particularly the intensive group in comparison to the standard group. So again, that shows those who are on intensive treatment group, there is a significant reduction in the renal events in comparison to the standard group. So that shows that probably the gliclazide modified release is actually superior and gives some sort of renal protection in comparison to the conventional group. Again, if we see the further dissect the standard therapy and intensive group in the this advanced trial, there is a 65% risk reduction in for the ESRD and 20% reversal of the normal albuminuria. And there is a 46% reduction in the ESRD. Advanced and advanced on has clearly shown there is a 46% reduction in there. And if we take no CKD patients, here actually the reduction is better outcome. Reduction is by 84%. If those who are in CKD stage 1 and still they are getting the benefits by 66%. So here the guidelines, we have ample of guidelines, AS, ADA, other local guidelines, RSSDI, CEPIS, NICE, all are actually endorsed the use of sulfonylurea for the management. Our own RSSDI ESI guideline that also shows newer generation sulfonylurea have demonstrated superior safety mainly due to reducing hypoglycemia. They improves cardiac profile. The sulfonylureas, particularly gliclazide modified release and glimepiride, have a low risk of hypoglycemia and preferred in cytostia patients. So sulfonylurea remains central to the management of diabetes across the world. So WHO 2020 recommends that this recommended sulfonylurea is a second line option in most of the patients after considering the efficacy, cardiovascular safety, overall serious hypoglycemic risk, tolerability, and cost. So these are the guidelines which has clearly shows that still sulfonylurea has its own place. If you are thinking about considering the cost and access, probably sulfonylurea plays a critical role there. So the long-term trends in the anti-diabetic drug uses in US, the real-world evidence in the patients with newly diagnosed type 2 diabetes, despite of introduction of newer therapies, sulfonylurea has remained the most popular second-line agents. The rate of intensification with sulfonylurea and insulin remained consistent over time. So long-term experience with sulfonylurea as a second line proves its efficacy, safety, and acceptability. So at the end, we must never forget that 80% people with diabetes lives in the low middle income countries. So we have a lot of misconceptions like regarding the efficacy, hypoglycemia point of view, weight gain point of view, beta cell apoptosis, durability, concomitant use, and cardiovascular renal risk. So the facts are regarding the efficacy point of view, probably it has unbeatable efficacy. Regarding the hypoglycemia point of view, modern sulfonylureas have minimal hypoglycemia compared to other sulfonylureas. From the weight gain point of view, they are found to be weight neutral. From the beta cell apoptosis point of view, they are beta cell friendly. From the durability point of view, they have similar durability profile like DP4 and SGLT2 inhibitors. They can be concomitantly used with insulin. And from the cardiovascular renal point of view, they are found to be absolutely cardiovascular and renal safe. So modern sulfonylureas with glimepiride and glycolizide modified lipids are therefore the sulfonylurea of choice for other thing. So from Odisha, thank you. Our author is continuing. Thank you for everybody. And any questions, anything we can discuss now.
Thank you, sir. Thank you so much for beautifully presenting the topic. And I would request the audiences that if they have any questions, please put here. I will read them out on your behalf. Sir, let me check once. What are the questions? Yes, sir. So we have received one question, that is, how do second generation sulfonylureas compare to other oral antidiabetic agents in terms of efficacy for glycemic control in type 2 diabetes?
I think I have discussed that part that if you'll see the efficacy point of view, probably sulfonylurea has a potential up to 1.5 to 2%, which is not there in any other OHA. If you'll see DP4, it is 0.8%. If you'll see AGIs, it is 0.5%. If you'll see SGLT2 inhibitors, again 0.5 to 8 to 1%. And if you'll see GLP-1, it is 1.5 to 2, but they're again injectable. And insulin, of course, it has significant high. Then again, this is injectable. Among the OHS, probably sulfonylurea has the highest potential with the range of 1.5 to 2% reduction in H1s.
Right. So another question received: what criteria should be determined with patient with type 2 diabetes, a suitable candidate for choosing the second generation sulfonylurea therapy?
Yeah, this is actually not criteria. Actually, second generation sulfonylurea means, as you will see, the all guidelines everybody has endorsed now that you can use SGLT2, you can use DP4 inhibitors, you can use GLP-1 antagonist. We don't have actually, we are not against that. Here we want to discuss, suppose someone is already on SGLT2 and GLP, still the blood glucose is not controlled. If someone is on SGLT2 or DP4, still blood glucose is not controlled, patient don't want to take injectable. So here sulfonylurea is the best drug. You can safely use and it has absolutely safe. There is no complications and you can safely use those group and give HbA1c lowering will be very good in those groups.
Thank you so much, sir. Next question is, what are the potential long-term outcome and complications of using the second generation sulfonylureas?
Actually, as I have clearly shown, there are a lot of myth like in the sense of we can have weight gain, the risk of hypoglycemia will be high, they increase the risk of cardiovascular disease. I have clearly shown they are cardiovascular neutral. The weight gain is very minimal. It is around in the range of 0.5 to 1 kg. The risk of hypoglycemia, if you are using properly in a proper way and not a unjudicious increasing the dose, probably the risk of hypoglycemia also significantly come down. So long-term complication is not like that. From the drug itself, there is no significant complications in long term.
Sir, I received one last question. In what scenario is it appropriate to use second generation sulfonylureas in combination with other anti-diabetic medication, and what should be the considerations?
As I have clearly discussed probably in my last answer, That's as the OZ guidelines endorses, you can go SGLT2 or a GLP-1 for the CSCBD risk factor is there. If heart failure is there, SGLT2. If CKD is there, then SGLT2 GLP-1. And if particularly if the CVA is there, then glitazones and GLP-1 shift agonist are there. So you have used that. Still, blood glucose is not controlled. Suppose someone is having ASCVD risk factor is there, you have already started SGLT2, blood glucose is not controlled, and patient don't want to go for oral injectable therapies. So you can add glimepiride or you can add glitazide because they are CV neutral and they are very good potent. They can reduce HbA1c. Similarly, suppose another group of patients are already SGLT2 and DP4 still not controlled and patient don't want to take injectable. You can add glimepiride or glitazide, HbA1c can significantly come down. So what my intention was tell that they are absolutely neutral from the cardiovascular point of view, and so they are absolutely neutral from the heart failure point of view. So they can safely used in any sort of combinations if someone is actually hesitant for injectable therapies.
Right, sir. Thank you, sir. Thank you so much for answering these queries. I think there are no more questions. I would just like to check once again. No, sir, there are no more queries. So, sir, with
Thank
that
you.
note, I would like to extend my sincere gratitude for your insightful presentation, and sir, your expertise and engaging delivery truly made the session very valuable to all our viewers. So, thank you so much for that, and of course, thanks to all the audiences for watching the session and for putting your questions. I would like to thank everyone for joining it. Thank you so much, sir, for giving us your precious time. Thank
Thank
you, sir.
you. Good night. Good night.
Thank you. Thank you, sir. Take care.